Hematological complications. Okay, this is something that we all have to be aware of. The two most biggest ones are DIC. This is disseminated intravascular coagulopathy. Basically, the body gets so overwhelmed and stressed that it both clots and bleeds at the same time. Okay, it is initially a prothrombic condition, meaning it's going to clot, it's going to cause multiple emboli and multi-system organ dysfunction or failure, and then it progresses to consumption of every single coagulation factor that the body has, which then leads to bleeding. Okay, it is very, very hard to turn this around. Fresh frozen plasma. We try to do that to try to replace that coagulation factor that's been consumed. But again, DIC is one of those that is just very, very hard to turn around. HIT, heparin-induced thrombocytopenia. Obviously, you have to have given heparin to get this disorder. So basically, it is a drop in your platelets, which then can lead to bleeding. So anybody who's on anticoagulation and they just start spontaneously bleeding or oozing around like devices like IVs or central lines, probably getting your coag panel as well as a anti-TNA lab and stopping the heparin. Transfusion-related complications, trolley. Transfusion-related acute lung injury is the one that'll kill people. You really want to, this is why we have people consent for blood. We go over this complication as a risk every time we give a blood transfusion. Not necessarily due to volume overload, so diuretics are not indicated. The best thing is to just stop the transfusion and give supportive care respiratory wise. We may have to even intubate if needed. But it's just one of those things that if you are having somebody with an acute transfusion, whether it does not matter if it's component or whole blood, if it happens, if they start having shortness of breath, we need to stop the transfusion and support them. Hypokalemia is something that we need to be aware of with packed red blood cells or component therapy. There's citrate within the packed red blood cells, and so after so many packed red blood cell units, the calcium in our body then binds to that citrate, causing hypocalcemia. So a lot of times, if we've given, like, if we anticipate either giving like 4 to 6 or more, we will automatically, prophylactically give them calcium along with their transfusion. Okay. Metabolic acidosis, again, hyperkalemia, due to hemolysis. That's it. The banked red blood cells are a little old, or they're going through a smaller line and they get damaged somehow. Anything that leads to hemolysis even leads to hyperkalemia, which then leads to metabolic acidosis. So there's something to be aware of. Hypothermia during the transfusion. We try to give the transfusion through a Belmont, or a level 1 transfuser, which basically warms the blood before it gets to the patient. But sometimes if you don't have that, this is cold blood, right? So it could potentially cause the body's temperature to drop. Right? Hypothermia, why we care, okay, is part of that lethal triad. So in trauma rooms, in the back of ambulances, it gets extremely warm. We try to pump up the heat as much as possible to conserve the patient's body temperature, okay, with no regard to our safety and or our comfort, right? We are basically stripping them head to toe. Trauma naked is a thing. We need to see every single part of that person's body. So bra, underwear, everything comes off, but we then try to cover them as soon as possible to conserve their body heat so that we are not increasing the likelihood of getting hypothermic and increasing the likelihood of a lethal triad. But what does hypothermia do? Why do we care, right? So hypothermia decreases SaO2, SaO2, saturation of O2 decreases with hypothermia. Why do you think that is? If your arms and legs are cold, what happens to your blood? Shunts, right? Do you think your body is then going to be actively trying to move the blood around to other things if it's cold? you have thicker, sludgier, more blood. It doesn't want to move as fast, which leads to then SaO2 drop, which we don't want, right? We don't want them to be hypoxic. And then you can see the so oxygen hemoglobin dissociation curve. I'm not going to necessarily test you on this curve. Just know that hypothermia causes the drop in your SaO2, okay, which then leads to lethal triad, which is why we try to keep people warm. All right, we're going to do a lot more wound complications in the next lecture, but just a few. So hematomal seroma. We talked about this a little bit. I hinted at it, right? If we don't close that bottom space in a deep wound, our body has just this ability to produce more fluid and fill that space. So if we don't kind of close down those spaces, it's going to cause a seroma. It's just a buildup of our body fluid in a space, in a cavity, in a whatever. Okay. Normally small ones resolve on their own, but if it's large, we'll normally have to aspirate it and or open it to decompress it. Early fascial dehiscence. So, remember, we haven't really gone over our body or our belly like layers yet, okay? But you have skin, muscle, or skin, fat, fascia, then muscle. So that fascia is basically that linea alba, right? Remember that guy? Where everything kind of comes together from the right and the left, and that is where diastasis recti happens. That's where your ventral hernias happen. So that fascia is what we close to, what we cut, and then close back together. If it is very fragile or it's very loose already, you're going to be at an increased risk for that to break down. Or if you have edema in your bowels or any sort of things that's putting pressure on that, like say you're just obese, right? You're putting pressure and tension on that repair of your linea alba. Okay? If you see salmon-colored fluid coming from a midline incision, that means that most likely that fascia is broken down enough that your intraperitoneal fluid is seeping out of the wound. That fascia is broken down enough that it is not open, and all of the fluid that your intestine swims around on a normal daily basis is coming through that wound. That is fascial dehiscence. Now, later unrecognized fascial dehiscence, you'll have incisional hernias. So these are not necessarily potentially, especially with incisional hernias, your skin is still going to be intact, but the bottom layer, your fascia, is not, so that intestines can actually come through that hole and cause, or fat, and cause hernias. Okay, we'll talk more about that in our actual hernia lecture. But basically, with later undiagnosed hernias, the skin is healed, so you won't have anything coming through the skin, but it won't be any of these two pictures. But you'll still feel a little hernia of some sort, whether it's fat or a little outcrouching of your intestines coming through that hole. You still have a hernia, that's a hernia, okay? But it's incisional, we caused it. That makes sense? Yes. Cool. All right, surgical gut infection. Anytime we have surgical gut infection, we are going to open it, we are going to irrigate it, and we are then going to pack it. We are not going to close it again. So this guy on the bottom, you can see it's very red, very angry looking, it's very swollen. If you were to touch that, pus would probably come out, pregnant fluid would come out of that incision. Okay, we are going to take that one back to the OR, open it up, cut away any necrotic tissue, really irrigate it out, and then instead of closing that skin again, we're going to pack it. Which I don't think we've gone through packing yet, but we will. Okay. We're just going to avoid the temptation to reclose. If it's infected, don't close it. All right, compartment syndrome. Everybody's heard of compartment syndrome? Yes. Good. Right, so it's normally from a long bone fracture. But you can get it other places. You can get abdominal compartment syndrome. Okay. For this, we'll talk more about abdominal compartment syndrome in one of the other belly lectures. This is really just for the long bones, okay? We'll talk more about it in the next lecture too. Pressure that causes a impairment to perfusion, okay? Whether this is just swelling or this is a basically, whether it's fluid or just swelling of the normal tissues, you're putting pressure on that vasculature. Okay, basically clamping it off from that compartment, which then leads to ischemia, which then leads to necrosis. If you don't have blood going to the area, it will die. Your first sign, pain out of proportion, meaning they are at 12 out of 10, and you're looking at them and you're like, well, the leg doesn't look bad. It's maybe a little tense in those compartments, but they are pain way out of proportion. And then as soon as you get to the point of loss of function or loss of pulses, that is a late finding. You're already behind the game, and your muscles are already dying. So when you have somebody with a long bone fracture and there's pain out of proportion, that should be your first sign to look at the compartment to see if they are truly overpressured. Okay. And then prevention, we go through the skin, through the fascia. It's called a fasciotomy. You can see it here. Okay, we don't ever close those fascia back up. We'll close the skin once the swelling has dissipated. But basically that fasciotomy, we go from, say it's for your leg, we'll go from knee all the way down to your ankle and open up every single compartment in your leg, in your lower leg, okay? So 2 incisions one on each side. I think on the lateral side we have the anterior posterior, and on the medial side we just have the deep. So there's a lot of fascia that we go through, but as soon as that all is open, it'll decompress, and those vessels then can reperfuse the leg. Okay. We can either cover this with just a wet to dry dressing. Most of the time now, though, we put them in a fluid bath, which we'll talk about. All right. So lateral side, you have the lateral component or compartment. Okay, we find this interfascial septum, and then we cut on either side all the way down. And then on the medial side, we'll find the edge of the tibia, cut into the deep, and then into the posterior. Okay, and we are running literally the length of the bone. If there's any little part that isn't, say like you leave an inch or 2, that's still potentially enough room for that to cause pressure and to cause that vasculature there to no longer have the ability to flow. So we really have to make sure that you get all the way down. All right, abdominal compartment syndrome, very similar, not associated with any like broken bones or anything, but this has to do with massive fluid resuscitations and fluid shifts. Okay, we're in the belly for a long time, or there's massive amounts of trauma to the internal belly organs. Our body and our intestines swell. It gets adenomous, and then we can't actually close the belly without causing a lot of that increased pressure intra-abdominally. And when we close that fascia, close that skin, if it's too taut, you're actually going to put all that pressure on your aorta, on your renal arteries, like everything that's in there, right? So your renals are going to start to not work right. Your intestines aren't going to work right. You're not going to produce urine. And so it's pretty pronounced when you see it, okay? The only way to properly assess this, though, is if they're paralyzed. So these people are normally intubated still. They're normally in the ICU. We'll look at their lactate. We'll look at their urine output. They're most likely acidotic. Okay. If the patient is even with like a -5 RAS, right, they're in a medically induced coma, they can still involuntarily guard, and that could increase their pressure if they sense pain, if their body, like central nervous system, senses pain. Okay, involuntarily guarding, increasing that pressure. So we need to paralyze them completely. We then check bladder pressures, and if it's over a certain number, then we know that they have abdominal compartment syndrome, and we have to go back in and open them up and leave them open for an extended period of time. So this is a makeshift abdominal closure, say temporary abdominal closure. The kind of the orange film that's over top is called Ioban. And basically what that we have underneath is we have what's called like a pagoda bag or a sterile IV bag. Basically something that's going to be between the intestines and any towels or suction or wound vac, right? We have to protect the intestines because if one of these little grains were to attach to an intestine, it's going to erode through and bleed and cause perforation. Okay, so we have to protect the bowels. Then we put some sort of, this is just a blue surgical OR towel they laid in there. They have JP drains laying on either side to pressure, but it's open. The entire abdominal cavity is essentially still open. Okay. There's other more expensive, we have the Apthera device, which we'll talk about later. That's a better, more self-sustained device that we can actually put up to negative pressure. Alright, decubitus ulcers, risk factors, sedated, or people who are sedentary, immobile. There's many different spots in which we can get them, but basically those are going prominences. This is why when you are even in the med-surg units, like you want to turn your patient every 2 hours, right? You want to make sure that you're relieving those pressure points so that it doesn't cause it to degrade, like that tissue should degrade. Okay, first thing you'll see is just redness over the prominence. Maybe a little painful, maybe a little sore, but it's just red. It'll blanch when you touch it. Everybody understand what blanch is? You touch it, turns white. Take your finger off, the color returns back to red. Okay. After a while, with that erythema, it'll then have that tissue actually break down and cause an ulcer, and then you'll have exposed fat, bone, and tendon, depending on what stage it is. Adequate nutrition is a prevention. You need to have, like someone who's gone through surgery or who's already malnourished will need to have extra protein. So having the nutritionist on or the dietitian on the case will help. Make sure that they're getting adequate nutrition, doing those frequent turns, padding those pressure points. There are special beds, especially for people who are going to be immobilized for a long time. They actually have, I think it's called an aero bed. And basically, it's a nice big computerized bed where you say, I want this spot to be up. And so it then automatically just shifts the air in the mattress for to have that side up. And then it's very expensive and most hospitals don't have it. But they do it. Anytime we see infection of these deep tube ulcers or necrosis of these deep tube ulcers, then we have to do incision and drainage. And debriding all of that necrotic tissue, otherwise it's just going to get worse and the patient's going to get septic and die. Okay, in terms of staging, okay, you have redness, then you have the erosion of the epidermis and sometimes some of the dermis. Okay, it's going to be like a raw sore. Once you get to stage 3 of full thickness tissue loss, so now you're down to like the fat. Okay. Stage 4 is now you have full tissue loss with exposed tendon or muscle. So now it's gone through even the fat. Bless you. Okay. Unstageable, sometimes if it has an eschar or that black necrotic skin scab, we might not know exactly how far and deep it goes until we debride that off to see how deep we actually have to go. Okay. All right. I would know, not necessarily pictures, but if I were to give you a example of a D-cube ulcer of the depth, know which stage it's at. All right, post-op fever workup. So post-op fevers, you really have to be above 101.5. Okay, anything below that is a low-grade fever. We anticipate, or basically already kind of think it's maybe atelectasis, or it is just a normal post-op inflammatory. But if it gets above 105, you really have to, work that up. Okay, we'll do another little HPI where it's, do you think it's atelectasis that maybe has turned into pneumonia? Do you think it's a UTI, or is there sort of post-site infection? Okay, do they have any of these things? So culture-wise, we're going to take blood cultures. We're going if they are not intubated. You can, basically, we really need it to be a deep cough and be like an expectorant type cough. A little puny, pitiful type cough isn't going to give it, and if it's just spit, it's not going to do anything. So sputum, yes or no. If they are intubated, we will absolutely we will kind of tickle their lungs and make them cough, and by tickling, it really is a suction catheter that we put down their ET tube that basically goes down into their lungs, and we do it enough that they start coughing, and then we'll suction up that sputum, so that's deep sputum that really will have the offending bacteria if it's a pneumonia. Okay, we'll do a chest X-ray. We're going to inspect everything, not just IV sites. We're going to look at all of the skin, make sure we're not missing a deep tube ulcer. Make sure, especially if they're a trauma patient, that we're not missing some other injury that we missed. Okay. Discontinuing any invasive devices that no longer are needed. Do they need that central line? Do they still need the Foley? Do they still need all of their drains? We will look and assess each and every one that is attached or within their body and make a determination on whether or not we can remove it or not. Okay. Fever occurs pretty readily. 40% of patients will have a fever post-op. It's up to us as practitioners to figure out why. Is it simply just a post-op fever that we just need to monitor, or did we cause it? So, out of these, 1, 2, 3, 4, 5, 6. If 3 or more of the above are present, more than likely they have a bacterial infection. So if they have preoperative trauma, any preoperative trauma. Now, this doesn't mean like a week ago they sprained their ankle. Okay, this is they came in as a trauma. They were admitted from their traumatic injury. Okay, if their ASA class is over 2, if the fever onset is after the second post-op day, right? Because after 48 hours, that's normally when we start getting into infectious type of timelines. If their initial temperature elevation is above 38.6, which is 1.5 for people who hate metric, like me, post-op white blood cell count over 10. Now, if their initial baseline post-op, or first day post-op white blood cell count was like above 10, it's going to be, is there an elevation of their white count? Okay, there's a lot of times, especially with people who are already infected, already septic, they may have a white count of 15. Right, so after the OR, after we've done something, after we've drained the abscess, more than likely we should see a decrease in their white blood cell count, because now we have source control. We've taken care of and washed out that abscess. But if on post-op day 2 or 3, they go from the 15 up to 22, an increase in their white blood cell count, then we know that, okay, we missed something, or it's deeper, or what we did that wasn't enough. Okay, and then post-op serum BUN of 15 or greater. Okay, so 3 or more of these things, most likely will have a bacterial infection somewhere. ENT complications, really only we see these if we're doing surgery in that area, or if they have ototoxicity from aminoglycosides or vancomycin. Pretty rare though. Okay, there's not much to do other than stopping the offending agent, getting ENT involved. Okay, if it's epistaxis, you can humidify their O2. Do they even still need nasocannula O2? Okay, if they came in with a MTA, right, and it's now a week later, did we give them a sinus infection because of the MTA that was placed in their sinuses? Okay, did they vomit and have vomit come out of their nose when we were resuscitating them, which is very common? Do they now have a sinus infection because of the aspiration potentially to their sinus cavities? There's a lot of things that you need to think about. Nosocomial infections, okay. I don't think I'm actually going to actually test you on the actual percentage. It's just this is something you should know. 36% of the time, we are the cause of the surgical site infections. Okay? 30% is C. diff, 17 catheter-associated UTIs, 9% is central catheters, and then 7% is VAC. What does this make you think? This is a critical thinking question. Using this, as these are the main causes of nosocomial infections, what does that lead you to believe?
We need to be better.
We need to be better, yes. These are all things we do to the patient, right? There's nothing that is on this list that is a, not other person associated thing, right? So we need to be very careful when we're doing these things in order to help lessen the risk of these things happening. All right. So these are tidbits for phase 2. Okay, keeping your patient alive on the surgery service. You always round on the sickest patients first. Okay, go to your ICUs, go to the sickest person or the first, most recent post-op patient on the ward. That's the first one you go to. Okay, the last one you go to is someone who's been there for weeks and they're just waiting for a SNF or a skilled nursing facility. Okay. If the nurse calls you, even in the middle of the night, even at 3 a.m., and they say something's not right with the patient, they are with that patient 12 hours a day. Okay, they will sense a change. Do not blow off your nurse. Okay, they are the ones who are getting the daily reports. This may be your first or second day on the rotation. They've been with this patient every day for the last month. Right? They know the patient's baseline way better than you. Even if you were there at the first initial start of their admission, right? Are you with them bedside for 12 hours a day? No. So always trust your nurse. Does not hurt to just go see the patient, put eyes on them, because your residents above you will say, hey, did you go see that patient? Because you have to tell the resident, the chief resident, or whoever resident is above you, right? Hey, I got this nurse paged me about this patient. The first question out of their mouth is, did you go see them? If your answer is no, not yet, it should be followed up with, I'm going right now, I'm just letting you know that I got this text, or I got this page. Okay? Always note your GCS. Okay? Assess ABCs if compromised at all, call for help. Start ACLS and CPR if they no longer have a pulse. Okay? Always consider your MIs and PEs. Anaphylaxis. Remember your drugs. Always keep your senior resident or your attending in the know. There's a very morbid phrase that I have. It's not the first time I've heard it. Many surgeons have said this to me. So I apologize if this offends anybody. Hopefully it doesn't. But don't be the only person with your hand on the coffin. Okay? If you're the only person who knows something and that patient dies, it is on you. So don't ever be the only person who knows the information. Always tell somebody else, even when you're a staff PA. If there's something going on, talk to your supervising or your collaborating physician. Always have someone else in the know. Doesn't matter. Okay? Especially early on in your career, bad things happen, bad things will happen. You will hurt patients. It's just a fact. You will hurt patients one way or another. It may be very small, then you may be able to catch it before it actually does damage, but you may not. Okay? You just kind of take it, you learn from it, but always make sure that you're not the only person who knows. All right, ICU death spiral. We're going back to that SIRS, the systemic inflammatory response syndrome. You have to have more than 2, so a high temperature, tachycardia, tachypnea, and leukocytosis. 2 or more. Okay. If you start SIRS and then you find a source like pneumonia, UTI, they have an intra-abdominal abscess. Okay, now you have sepsis. So if you have a nurse call you and been like, yeah, they're tachycardic, they're maybe a little altered, they have a fever, you should go see that patient because more than likely they are down the spiral of going into sepsis. Okay. Septic shock is when you have sepsis, but then now you have end organ failure. Their kidneys stop working, their liver stops working, they start going into heart failure. Okay, they're so encephalopathic that they're just altered. That's end organ failure. Okay, that's when you have septic shock. And then if you are in septic shock, it is very, very hard to get out of this. The further you are down into this spiral, the harder it is to get back up. Okay, so this is why if we see someone in Surg, we start that initial fever workup of get the cultures, get the chest x-ray, check all the lines, do the full body exam, make sure we're not missing something so that we're not falling face first off of this cliff and we can't recover. Alright, a 71-year-old patient undergoes surgery for colorectal cancer. Post-operatively, the patient developed an intra-abdominal abscess. Despite antibiotic therapy, the patient has persistent fever and develops hematemesis and melena in association with a purpuric skin rash. Laboratory tests reveal a 70 platelet, prolonged PT time, and decreased fibrinogen. What is the most appropriate treatment for this patient's suspected condition? What do you think they're in? Could be sepsis. What's happening to their body? What's a purpuric rash? What is that indicative of? Clots. But then what does hematemesis and melena mean? Bleeding. So if you have clots plus bleeding, what does that equal? DIC. So what's the treatment? Is platelets gonna do enough? Does cryo have all the things in it that you might need because all of their clotting factors are depleted?
Yep.
Yeah. So do you want to give heparin to this patient? No. Draining the abscess? Yes. Okay. So this is kind of a twofer, right? You have to treat the DIC, but you also have to treat the abscess. If you don't treat the abscess, you're not going to treat the DIC. Okay. What's another thing you can do instead of cryo? Fresh frozen plasma. Okay. So the correct answer technically is drain the abscess, then cryo or fresh frozen plasma. You have to treat the infection first. Okay. It's a little weird. You're most likely going to be doing it at the exact same time. But if you don't treat the abscess, you're never going to, that you can give them all the plasma that you want, it's never going to change anything. They're going to continue down this pathway. Does that make sense? Kind of? Okay. Next question. All right, let's move on to the next one. Management. All right. Any questions on that last one? Post-op complications? No? Okay, so now that we've gone through post-op complications, now you have a wound, now what are you going to do about it? Okay, those are your objectives, read them over at your leisure. So, wound healing physiology. What actually happens? Okay, you have a wound, no matter what it actually is caused from, you first go through inflammation. Inflammation is your first stage of healing. Okay? An infusion of red blood cells, all of the inflammatory markers. Okay, you're going to have vascular constriction, coagulation. You're going to hopefully get hemostasis, meaning a clot or a scab. Okay, this can occur within minutes to normally first few days to really solidify that scab. Okay. Next, you go into mitigation and proliferation. So what this is that it's now starting to epithelialize over the incision and the wound. That starts normally within 24 to 48 hours. This is how the wound actually contracts. Okay, so you're most likely going to see this in the secondary intentions, right, when they're healing from the inside out, versus if you've already closed down the skin and it's closing from primary intention, in the top down, all of this is kind of happening underneath the skin, and you're not really going to see it. Okay, so when you get to that migration and proliferation, you're going to actually see that wound start to get smaller. Okay? That's what we want. And it normally peaks within the first 1 to 2 weeks. People who are chronic healers or diabetics get stuck in this proliferation phase, this migration proliferation phase. They just don't have enough to actually contract that wound down. Okay. Maturation, this is the final stage of the wound healing. This happens over weeks to months, so the skin is actually, you have a nice scar, okay, but the underlying tissues are still remodeling, they're still getting all that fiber matrix underneath the skin, which is why we say, you know, it's going to take up to 6 months before we start any skin revision creams, because it's still going through this last phase of truly getting to whatever that scar is going to look like. Normally, by 6 to 8 weeks after the insulting injury, you have about 80% of skin original tensile strength. So this is why someone who goes and undergoes a major abdominal surgery, and it's not just the ports, and we are actually cutting them open in different regions, right? We say don't lift anything heavy for 2 months. We're letting that skin really congeal and have that matrix underlying it, so that it's only at 80% tensile strength. You can still cause incisional hernias if you do too much and you break this component apart too soon. All right, we already went through closures. Just a review. Primary tension, remember, it's from the top down. Secondary heals by itself from the bottom up. And then tertiary intention is just a delayed primary closure. We allow the wound to be less infected. This doesn't really happen too much. Not very often do we do tertiary intention, but it's still something we can do. Okay. All right. Approach to the acute wound management. How do you manage the initial one? Right. You want to get hemostasis. You want to stop the bleeding. You want to try to irrigate it out as much as possible. You want to try to prevent any further injury, and assess the ABCs. If they're no longer, if you stop the blood, stop the bleeding, but they're no longer breathing, does that matter? Not so much, right? So before you go on to do the rest of your wound management, you still have to have, just do a real quick ABCs. Are they breathing? Do they have a pulse? Is their circulation intact? All that jazz. Okay. Bedside assessment is next. You do a rapid assessment. You want to know the nature and severity of the wound. A gunshot wound is treated very, very differently than a chainsaw wound, or a cut through glass, or stepping on a rusty nail. Right? The treatment changes depending on what actually happened and the injury pattern. Adequate sedation or anesthesia. Right? Is this something that we can just do a local, or is this something that really needs to be examined in the OR? Okay, if we have to potentially close the galea, which when we'll talk about the skin layers of the scalp during the head lecture, but if we have to actually, if the injury has actually gone through the galea, we're most likely going to wash that out in the OR. Okay, not necessarily due to pain control, but we really want to make sure that we evaluate that and close that galea, because that's the basically last line of defense between the outside world and the bone. Okay, the periosteum of the skull. You don't want to have any infections there, right? You don't want to have any chance of osteomyelitis of the skull. That leads to very bad things. Okay. The wound should be examined for all of these things. So when you are doing a laceration repair, all of these things need to be listed as something that you looked at and measured in your notes. Okay? I want to know how deep that wound is. I want to know how wide it is. I want to know how long it is. Okay? What's the tissue viability? Is it very thin, like 90-year-old skin? Is it already necrotic? Is it already infected? Surrounding damage to nerves, blood vessels, and muscles. What's their PMS? Right? Can they actually move all, like say it's a wrist or a hand, can they move all of their fingers? Can they move all of their tendons for every single one? If not, they might have had a tendon injury and you really shouldn't be messing with that unless you have a hand surgeon or an ortho guy or whoever go see that. And maybe they have to do some underlying repair in the OR before you just close the skin. Again, consider operative washout depending on how big it is and how bad it is. You still should cleanse and irrigate every single wound that you intend to close. Okay? Even the ones that you don't intend to close, you are still irrigating and washing out and scrubbing, which is a lot of times why you do the local anesthetic before you actually start washing it out. These can be very, very tender and very painful, and it allows you to really be able to dig if they can't sense pain in this region, to make sure you get all the gravel, all of the glass, all of the wood, whatever potentially dirt is in that wound needs to come out. And then what is your proper closure? How are you going to close this? You want to close with staples? You want to close this with suture? Is this something that is a gunshot wound and needs to heal by secondary intention, and now you need to teach them how to do it, right? So these are all, this is the approach from start to finish. All right, contusions. How do you fix contusions?
Let it go.
Sympathetic care, right? It's normally treated conservatively. The only ones you really need to be aware of is the ones that still have the bleeding little vessels in that hematoma, and that hematoma or contusion is getting larger. Okay, that may need actual compression to try to close off those bleeding capillaries so that it doesn't become a hematoma within a contusion. Okay, you'll see this a lot with older people, especially on anticoagulation. They fall down, they have a huge bruise on their butt, but you look at them like an hour later and their butt is twice the size it was, probably still bleeding into that muscle. So complication hematoma, again, direct pressure is the first line. We don't like to go in and actually like open up and drain it and cauterize unless we absolutely have to. Most of the time we will actually use IR to go in, basically within the vessel and actually find the vessel that's still bleeding or extravasating. I mean, bleeding outside the vessel. Okay. And they will actually put a glue or something ligating that vessel so that it's no longer bleeding from the inside, so that we don't actually have to cut their skin and evacuate that hematoma. It will eventually go away, but we have to first figure out how to stop the bleeding. Okay. All right, abrasion. This is superficial damage. Goes through the epidermis, through the dermis, or to the dermis. Okay. Can be basically think of like your road rashes, your Indian burns. You have to have destruction of the epidermis and partial dermis. Okay. Normally, if we let it's healed to left to heal by secondary intention, should close within 7 to 10 days. Everybody here has seen their knee or some part of their body on cement. This is what that was. Okay. Now you can have it be complicated by surrounding things. That first picture on the left is someone that I took care of who got crushed under an 18-wheeler. So he was dragged on the cement, but also tore open his inguinal region. So this has a skin or a muscle flap, with loss of tissue over that muscle flap, surrounded by abrasion. This was very hard to keep dry and to keep clean because we had to protect that that flap over the vascular repair. Okay, so it's not just, it can be very simple, as like this is a little road rash, versus massive damage. If you have a extensive amount of road rash, you're actually treated as if you have a burn, and we most likely will put you in the burn unit. Okay, there's still that burn pathology is loss of epidermis and dermis, right? So you still have the weeping, you still have the skin dysfunction, everything that comes with a burn you can still have with an abrasion. Just depends on how bad that abrasion is. Okay, we do try to do debridement of these. We do not want to have traumatic tattooing. Okay, I had a girl, sweet girl, but unfortunately she was on a motorcycle and she was in yoga pants. Ended up falling off the motorcycle at very high speed. So then she had yoga pant material embedded in her abrasion. Okay, it took about a couple days of her coming in with her parents every day, and narcotics to have her sit there and have me pick out yoga pants from her abrasion. Okay, would it have been better to probably take her to the OR and scrub her? Maybe, but we were able to get it all out, and it didn't necessarily disfigure her in the long term. Okay. Exposed cutaneous nerves, very, very tender. Okay, when you get down into the dermis, basically your capillaries are exposed, your hair follicles are still there, but like your nerve endings are there. Okay, these are very, very painful. So most likely, depending on how big the abrasion is, we may actually have to give them narcotics for pain control. Just depends. Okay. All right. Punctures. 2 minutes. This will be the last one before the break. So punctures. Okay. Anytime something punctures the skin, you have to assume something's been left behind until proven otherwise. Okay. Whether it's a gunshot wound or a stab wound, you don't know what that bullet went through first before it went through them. If it's a knife, you have to make sure that that tip is no longer there. If it's glass, you don't want glass to still be in there, or wood, whatever, right? You always have to examine for foreign bodies. You may require x-rays first before you start debridement so that you can actually see if anything's there. Some things shows up on x-rays, some don't. Okay. Normally we leave puncture wounds open because again, just like I said many, many times this semester already, normally the stuff that we get stabbed with or punctured with is not sterile. So we leave it open and allow it to heal by secondary infection. Antibiotics are normally not required proactively or prophylactically. And if it becomes infected, that's when we start antibiotics. You don't necessarily have to start them immediately. Okay, if it's complicated, uncomplicated cellulitis, we just do oral antibiotics. If it becomes complicated, like it seeps deeply or starts going into sepsis or Surg, then we may need to admit them and put them on IV antibiotics. And then don't forget to update tetanus. We don't know. This bug is something that is very, very treatable. Right? You can get tetanus back to back in the same, next day. Okay. But if that person we don't know when their last tetanus was, you're going to get one. Because, like I said, tetanus is very preventable. It is a very, very horrible way to die. There's not a lot of treatment for it once you start going down that pathway. So it's not impossible to treat, but it is very painful for the patient. All right, take 10 minutes.
I thought she was going to send off with,
Thank you.
So we still have 30-ish more slides for the day. I will probably probably not.
would have had to restart like you did with the chunk.
I've been counting. What are you making? I like it. Is that your class mascot? Oh, no. You guys have to pick your class mascot. You guys have to pick your class mascot. Our class?
Oh, the frog. Were we the frogs?
Oh, yeah. Because, I mean, last class was not there.
That was so hard.
That's why the picture is on Discord.
Yeah. I think Aaron.
Can we vote which one I vote for Jan?
James, our master.
Yeah.
The frog.
I guess it's part of the whole thing. Oh yeah, that's good.
Probably was what happened. It's like do all of it, and then you get the overall solve it. That's my only game.
I think Dakota should be our mascot.
Let me know how it works.
Honestly, frozen. I like frozen factory. Like by the pool.
My go-to is on Miami Lakes or Beds. Called Lodge. Phoenix Lodge is like showing every day. They look like a dark swirl.
You're talking about
They call them lava flow in Hawaii, and I asked that when I was in wrestling, like, what the fuck is that? So they're called Miami Lakes. I think they're out.
they don't pet. Myrtle.
Here's the honest. Hey, money, we're not going to Myrtle. Shit.
That's where my family used to vacation when we were poor as shit.
Yeah. Oh, no, Cancun every year.
You have to go to that.
No, I'm kidding.
You're going to Vegas.
I would know.
distracted while you make it down to the side.
I haven't seen Pulp Fiction in a while. Let's talk about it. It's in a movie in general in a while.
Yeah.
My whole career, all of our careers, we've been talking. That's not about it. We've never had a fight that bad. Now we know what it is.
Alright, guys. Alright, 15 minutes stands between us and leaving. So let's go. Alright, laceration. So, with lacerations, this has to go into the subQ. Okay, it has to go through the dermis into the subQ tissues. Okay, normally we close these primarily, unless it is a dirty wound. We make sure that no debris is left. We really irrigate it and to really make sure that we're not closing around debris and that it is hemostatic. Okay, we may need to use pottery, we may need to use ligation, stitches, okay, but we need to make sure that it's hemostatic. Otherwise, if we close a wound who's still bleeding, you're most likely going to cause a hematoma. Thank you. Okay, we want to close these within 6 to 8 hours. Just like with the primary closures, it can go up to 12. Okay, just like with normal lacerations. Okay, but the bigger the wound is, the sooner we really want to get it closed. Otherwise, that tissue starts to dry out and can have an increased risk of bacterial invasion. Okay. Again, if contaminated, we do allow it to close by secondary intent. But with that, we may close, so for this one, right, say it's infected or it was a dirty wound, she got it, or they got it, let's say on a blanket cut or whatever, right? We might, because it's so big, we might put like 3 sutures in it so that it closes down a little bit, but there's still room for that fluid that's going to come, or if it becomes purulent, whatever, is going to be able to get out of that wound space. But still, it has a little bit of ability of, okay, it's already closed a little bit, okay? So we're closing it down a little bit, but we're not completely putting in 20 sutures and closing off the skin so that no fluid can get out, okay? If you do place a little bit more, say you put, like in this wound, 6 sutures, and the skin kind of touches a little bit, but you still think there's enough room for fluid to come out, we put wicks in the open spaces in between each suture or each staple. Okay, that means that the bottom of the wound still has the ability to seep out that fluid, and the skin, because now it has a barrier, that wick, okay, isn't going to allow that skin to actually heal, and it's going to heal from the inside out in those regions. Okay, so there is ways around of closing bigger wounds that we're technically doing secondary intent with the help of some primary intent. It just depends on the wound itself, okay? If it was really, really dirty, and we do not want to close it at all because the risk of infection is so high, we'll most likely put a wound back on. Okay. All right, crush injuries. These can be tricky because the outside of the skin may not actually show any crush or any injury itself. Now these you can actually see the skin's been broken. You have deep tissue damage, right? So you don't necessarily have to have an external laceration showing that damage. What are some of the things you should be looking for lab-wise if you suspect a crush injury? CK. Is it on there? No, not yet. Great. So CK, right? Creatine kinase. This is something that muscle breakdown, right? You have to check a CK. Snake bites can mimic crush injuries. Okay, we live in an area right now that has a lot of big venomous snakes. A snake bite, especially ones that like they don't, they get bit and then they wait a couple days before they come in because they think, oh, maybe it's a dry bite or maybe it was a snake that wasn't, or a spider that wasn't venomous, right? And then they come in with just this wound that's like necrotic on top. Might have been crushed, might have been something, right? So you have to put kind of two and two together. We can kind of see this with ultrasound. MRIs, sure. If it's an obvious crush or there's a mechanism of injury, like, yep, I crushed my foot between this and that, and now I have this, we really don't need to do any imaging, right? We have the history, we have the CK, we have labs. If we want to say they're unconscious, they're intubated, we don't know if it was a crush injury, maybe they got thrown, we don't know what actually happened, that's when we can do the ultrasounds and the MRIs to see like what is actually happening in their compartments. Okay. Compartment syndrome. These are the 6 to 7 Ps. Every year I feel like they add a new one. First it was 5, now it's up to 7. Okay? So, know these. They're building for a reason. Okay? So the we'll say 6, because pain is still pain. 6 P's of compartment syndrome. First one is pain. Out of proportion, pain with passive stretch. Next one, paresthesias. Once you start having paresthesias, the next step is going to be pallor, meaning they're not getting enough blood flow. Okay? You're going to have pyokilothermia, meaning cold. Alright, they're not having enough blood flow to their foot, it's going to become white and cold. Then you're going to have paralysis, then you reach pulselessness. Paralysis and pulselessness sometimes come together in the same time. So if you have either paralysis or pulselessness, you're late to the party. And that whatever is, that whatever compartment syndrome below it, most likely is at risk of dying, or is already dying. Okay? So these are in order of what happens first and what happens last. Know this order. Know this order. For everybody sleep, know this order. Okay? It will not be the last time you see this. Crush injuries are a big thing in trauma, so you will be probably tested on this at least twice. Alright, crush continued. So you suspect it. What can we do to basically state, yes, this is compartment syndrome? So we can do intracompartmental pressure checks with a striker needle, normally done by ortho. I don't think I've ever actually seen a striker needle, because ortho just takes them to the OR, and if it's over 30, they cut. Right? If it's less than 30, well, they just wasted a trip to the OR. But most of the time, if they're already contemplating doing the striker needle, they're already saying, yes, this is compartment syndrome. We're just getting a number to put in our chart saying, yes, this is compartment. Yes, we're doing a fasciotomy to not get sued in the future. Okay? So if their striker needle says that that compartment is 30 milligrams or 30 millimeters of mercury and over, it has compartment syndrome, and they will do a fasciotomy. So normally, what we can do in the meantime, especially as not ortho people, right, or not surgery people, if you're rounding and they are starting to have that pain out of proportion, pain, now if it's a fractured limb, don't go trying to passively stretch it. You will have pain out of proportion or pain to proportion of that injury, right? You most likely will see that with like major crush injury, okay? So, but you want to make sure that they're not hypotensive, right? Do they have a cold limb or both limbs cold? Do they have peripheral arterial disease, and this is just their natural baseline? Okay, so also remember, if they're hypovolemic, your body's going to try to compensate and reserve that blood for your heart, lung, and your heart, brain, and lungs. So your limbs are going to be cold. Okay, so fix the hypertension first, and then remove all constrictive bindings. A lot of times when I see this in the hospital, this is post-op day 1 or 2, sometimes post-op day 0, like they'd had ortho surgery in the morning, they'd put on this huge bulky joint splint, and then I round on them before they're going to bed, right? And they're like, yeah, my toes they're real painful. I can barely feel them anymore. It's just pins and needles, right? Because I don't own that splint, it's an ortho splint, I will call ortho and say, hey, I'm about to destroy your splint, you should probably come home. Right? That there is an unwritten rule in surgery that if you didn't do the surgery, you don't actually touch that suture, you don't touch that dressing, right? You don't necessarily know what they did underneath it. Okay, so always give that department the heads up, that service the heads up, really, right? But if they're in the OR, I say, okay, are you okay with me cutting down midline of their splint? I'm going to keep them in the splint, but I'm going to open it up so that they at least lessen that constriction around that joint or that limb. Okay, most of the time that's all that's needed, and that the splint was just on too heavy. Okay, but always call the service first before you try to remove. Now, if you're the one who did the constrictive dressings, you can take them off because you're going to be the one to put it back on. Okay, and then maintenance of limbs at heart level. We don't want them up. We don't want them like dangling down. We want them just in line with them to help. Okay. If they persist, fasciotomy should be performed within 6 hours. Why do you think 6 hours is important? What other adjunct do we have that we have to take down within 6 hours, or else it causes muscle death? Tourniquets. So when you think compartment syndrome, think tourniquet. That's what it's doing. It's closing off that compartment completely so that no blood flow gets past it. Okay, so both compartment syndrome and tourniquets have to be relieved within 6 hours, or the rest of that limb will have catastrophic results. And then the longer we leave this to the point of like 6 hours, even 4 or 5 hours, right? We wait that long to relieve it. You still have muscle breakdown. You still have all of those enzymes leaching out of those cells, breaking down. Okay, so once you then relieve it, your body or the patient's body is going to be basically flooded with all of these toxins, which is why you have elevated CK. You have to watch their kidney function to make sure that their kidneys don't get gummed up. Okay, they may have metabolic disorders, so we really watch them very, very closely for hyper K and their elevation of CK so that we can treat them and potentially put them on dialysis if we need to. All right, 12-year-old child has a fractured ulnar radius that is treated with open reduction internal fixation. The surgeon is concerned that the procedure will be long but did not perform fasciotomy. Which of the first signs of compartment syndrome is most likely to present first? I know. I know some surgical Spanish, or some Spanish, medical Spanish. Yes, pain. Anybody not believe it's pain? Cool. All right, moving on. So extravasation into subcutaneous tissues. All right. So we have IVs, catheters going through the subcutaneous tissues into a vessel. Right. So what happens if that device becomes dislodged from the vessel and is now just in the sub-Q space? Okay. If it's just normal saline, probably you're going to have some erythema. Probably you're going to have some pain, some swelling of the area, but it doesn't necessarily lead to death or tissue death of that area. But let's say it's chemo. Let's say it is something that is a solution that is very toxic to the sub-Q region. Okay, if we don't catch it soon enough, it can actually dissolve the tissues that it's surrounding. Okay, so you can kind of guess where that IV was in this person's hand. Right, you can see tendons. This person is going to need skin grafts in order to cover that. So something as easy as just checking to make sure that the devices that we place are still working correctly and in the correct spaces is very, very important, okay? Most of the time, because nurses are really good and you know, they quickly manage them, they quickly identify, oh shit, that's infiltrated, is what we call it. They discontinue that IV and then put it either somewhere else, but they don't allow it to continue. As long as it's, you know, caught pretty early and it's not a really caustic type of solution, normally it just heals without any complications. We use heat and elevation. But if it's really high volume, say it's overnight, they didn't go check, there's some hospitals that happens, or it's chemo, or some sort of other contrast agents. Okay, contrast is actually pretty volatile to our subcutaneous tissue, so we don't like it. Can actually lead to more very catastrophic events and necrosis of the skin. Treatment depends on the substance included, time of detection, degree of tissue damage. May just need conservative stuff, or we may need to do an incision and drainage to try to get as much of that fluid out. We may need to just aspirate it or treat the area with specific treatments. I'm not going to have you guys know the specific treatments. That's way more in depth than you guys need to know. But the last thing is skin grafting and or a flap. Right? If it's so deep that even a skin graft isn't going to cover it, we may need to have plastics get involved to do a tissue flap. All right, bites. You really have to explore, irrigate, and breed these. Okay, you must do an X-ray on any bite, no matter what it is. Teeth break. You don't want to be the person who leaves behind a tooth, whether it's human or bat or cat, right? It doesn't matter. X-ray it. You have to evaluate those wounds. You also have to, if it's over a joint, you have to evaluate the joint capsule. Ortho normally does this, but you guys, I think, yeah, you can do joint aspiration, so you should be able to evaluate a joint. Basically, you take sterile saline and a sterile syringe, inject it into the joint in a different area than the wound. If fluid comes up or bubbling comes up through the wound, you know your joint capsule has been violated, and then they have to go to the OR with ortho to have that joint washed out. Okay? Now, in terms of joint violation, if you do not feel comfortable doing the investigation, just pass it off to ortho. They'll be more than happy to do that. Okay? Normally, we let these heal by secondary intention. If it's an animal bite, you're more likely going to get a rabies prophylaxis treatment. Rabies, unlike tetanus, is very, very even harder to treat, right? Once you get to the hydrophobia and the hypersalivation, like there is no real treatment. And nobody has really, really come back from a severe rabies treatment. So you might as well just prophylactically treat it. Most human bites, give antibiotics. Okay? Consider them infected. This is one of the only wounds that we prophylactically treat with antibiotics. Mouths are filthy. Okay? So treat prophylactically with amoxicillin. I will say with rabies, so there's one that I think you may have done this exam yet or not. I'm not sure if you've done the toxicology yet. Bats, right? If someone comes to ER and they said, I woke up with a bat in my room, you will not find a bat bite. Their teeth are too small, so you just automatically assume that the bat bit them, and you treat with rabies. Even if you cannot find a bat wound, you will not. Their teeth are like needle bite, you will not find a bat bite. Okay? All the rest of them, use your clinical judgment, but for bats, it is a non-starter. You woke up or you have a bat in your house and they could have, or you don't know if they've touched you, just assume they have. All right, spiders, snakes and vipers. Spider, strong recluse. Okay, this is one I want you to know. There's another one, black widows, that are pretty decent too. But for brown recluse, they have a violin pattern. Starts, it actually looks like cellulitis, like a cellulitic type process, and then it then sloughs off. Okay, it becomes necrotic and dies, sloughs off. So this is a black widow or a brown recluse bite. Okay, becomes very, it's very nasty. For snakes, you have the neurotoxic type venoms, your cobras, your mambas, which we don't technically have here, but you will be going downrange to places that may have these. So they attack your neuro system. So you may get tremors, myalgias, you may have cardiac and pulmonary manifestations. Knowing what toxic or what venom or what kind of snake it was really mattered, because then that's what antivenom you get. Okay. For vipers, rattlesnakes, they have cytotoxic, so they're going to be more so destruction of your cells. Okay, you're going to have tissue necrosis, hemolysis. You may lead to compartment syndrome from breakdown. Okay, so know that there's two different types depending on what type of venom they have. All right, this is an FYI slide. Anybody who goes to a region that has these types of snakes, this is the Universal International Protocol for snake bites. So now you have it. Okay. All right. High velocity. Explosions, gunshots. Okay, you have extensive tissue damage. You may not actually see the whole extent, kind of like a crush. Okay, you may have one little hole, a bullet hole. Okay, or you may just have a little bruise. But if they have a blast injury, okay, it can basically cavitate in the body. All right. So we really have to not underestimate the severity of the injury, which is why we normally do a lot of radiographs and CTs to really understand their internal pathology to make sure. I see a lot of blast injuries with like gunshot wounds to the chest. Right? You still have the bullet path, but all of the lung tissue around that bullet path is now damaged because of the blast injury going through it. Okay, so you don't have just the bullet or just the, where the bullet went through, but all of the destruction from that extensive force going through the body. Okay. Treatment depends on where it is. Okay, if the overlying tissue, like we're not going to necessarily do extensive debridement of the lung. Okay, we're most likely going to try and do airway protective management. We might put them on a vent. But if it's like the leg, okay, we may have to actually go in and debride all of that, the necrotic injured tissue. And most of the time we'll leave it open and or delay closure. To delay closure. Okay. All right, amputations. So traumatic amputations, okay, most of the time, if it is severely mangled, there's no real other option other than doing an amputation. Okay. For the most part, especially initially, we will do what's called a guillotine. Basically, we are cutting off the rest of the dead tissue just straight through. Okay. Especially if we expect potential infection. Okay, we will then leave that stuff open. We'll put betadine soaked gauze on it, and we will go back either every day or every other day to potentially debride more tissue until we get to the point of we go back and great, there's no more dead tissue. Now we're ready to do an actual staged, like final amputation type deal where we actually make the flap and close the stuff. Okay. Initial is really just control of hemorrhage, ligating all those vessels, getting all that debridement out, trying to get all the necrotic tissue out. We want to try to preserve the maximum amount of healthy tissue because that's what's going to cover, potentially. Okay. We do try to take into account bone length and joint function. If we can get it at the knee or below the knee, they normally fare better. Easier to recover with a through the knee or below. If it comes up, then you have to deal with mechanics of having a prosthetic knee, right? Versus just you already have your knee, now you're doing more of a lower extremity prosthesis. All right. Kind of went through this already. So it's really just a review slide. Primary closure, again, we want to get adequate pain control. We want to debride it. We want to irrigate it. Okay, we want to use some low pressure systems, bulb syringes, gravity flow, pulsatile lavage. As long as it's low pressure, that's what we want. We want to use non-toxic solutions, so we're not using necessarily betadine, or not betadine, hydrogen peroxide. Okay, hydrogen peroxide does not differentiate between healthy tissue and dead tissue. It'll kill all tissue. So we won't use hydrogen peroxide for actual debridement or for irrigation. A lot of times you just need to use sterile water or normal saline, sterile normal saline. Okay? We don't necessarily irrigate with antibiotic solutions. Ortho will do this in the OR, because ortho is special and they don't like to play by other people's rules. But they're also dealing with very deep joint spaces and that kind of thing. Spine, neurosurgery might use a little bit of irrigation or leave an antibiotic solution behind, especially if they're dealing with osteomyelitis. Strong antiseptics really shouldn't be placed directly into the wound. So this is the betadine. Now there are certain circumstances in which we will, if it is an open joint fracture and they're going immediately to the OR in the trauma bay, we will pack that wound with betadine soaked gauze because we're trying to limit the amount of bacteria trying to get into that joint. But they're literally going to the OR next to get the whole joint washed out. Okay. Some orthopedic surgeons will do that, some will not. It just depends on the surgeon, but you can. Surrounding skin being prepped, and then immediate closure. Okay, secondary attention. We're going to do this again. A few little tidbits. Want to leave it open if we have concern for contamination or infection. Nutritional status is very, very important. Okay. Pre-operative corrective nutrition, extremely important for patients who recently lost more than 10% of their body weight. Okay, so these people, depending on if it's an elective or urgent surgery, if it's elective, we will try to increase their nutrition before we go to surgery to help boost their post-op healing. Or if it's something that we can't wait for, we will include nutritionist and dietitian in their care team to make sure that we are adequately giving them enough to boost their healing and get them back to a normal and or above normal protein level and so that they actually heal. We already talked about the disadvantages. Okay, so wet to dry, damp to dry. So when we have something that we are trying to debride, it is infected, it looks gross, it has a lot of fibrinolytic type tissue at the base, we want to do wet to dry. Now, we don't want it sopping wet because we don't want the surrounding tissues to become macerated, so we do damp to dry. Okay? So when you hear wet to dry, think more damp to dry. And we don't want it sloppy wet, we just want it wet enough that when we place it, it doesn't hurt, but then it dries, and then when we take it out the next time to repack it, it is pulling away some of that dead tissue to do some debridement for us. Again, you don't want to use dressing sponges. So these guys, they have a lot of fiber fibrous material to them. They lint. They leave behind little pieces of fibers versus just cotton gauze shouldn't. Okay, so you'll see on the packing dressing supplies or dressing sponges versus gauze sponge. If we're packing something, we want a gauze. Then on top of that, we want Telfa. These guys, okay? They have a gauze on the inside, but the outside of it is non-adherent. It has a very shiny coating to it, kind of like the outside of a Band-Aid, so that it doesn't stick to the wound. These are great for abrasions or things that are going to leak a lot. They have some absorption, but they don't stick. Silver nitrate. So when we have people who have these chronic wounds, I see these more so with the older population. They have skin tear and they have hypergranulation of their wound bed. Okay, so this is they had a skin tear and then their body their skin cells at that spot just don't function right, and so they continue to grow, but they're raw. They're not skin, right? It's kind of like the underside of the dermis. It's just a continuation of granulated tissue that's raw and painful. So what we do is silver nitrate. We stun that tissue, we burn it, and then most of the time it's enough that 1 or 2 treatments is enough to have it go back to normal healing, and it'll have that migration, proliferation, and that's closure of that wound. Okay? Now, with silver nitrate, the tissue will turn gray. That's normal. You also have to brief the patient and consult them and inform them that it may leave behind a tattoo of black. So it just depends on their skin. I haven't seen it yet, but it's still a complication that is a potential that we have to inform them that, hey, we're using silver nitrate that actually, cause the skin to flip back into a normal healing pattern, but you may be left with a black spot on your skin. Alright, punctures again. So narrow wounds, we insert the gauze. Now when we are inserting that gauze, we don't, if you feel underneath the skin, we don't want a baseball or a golf ball size, depending on how big that wound is. You want just enough that it goes through the wound, but it's not balled up at the bottom. You shouldn't feel the compartment underneath of balled up tissue or balled up gauze. Okay? You want it just enough that it reaches the base of that wound, fills the cavity, and then you have a tail on the outside that you can pull, but you don't want to stuff enough in there that you're actually causing necrosis, ischemia of the inside tissues and causing necrosis of that tissue wall. Okay? Which you can do if you pack too much in there. Leave a tail, cover with dressings. Normally we change these out. We repack either daily or twice a day, depending on how weepy the wound is, that kind of thing. You can still change the overdressing more than once a day, right? You don't want a sloppy, wet dressing if that wound is weeping a lot. You tell them to change it as frequently as they need to, so that a wet sponge isn't just sitting on top of their skin. But the packing really doesn't have to be changed for at least every day or maybe twice a day. And I try to have them if they're going to take it out in the morning, take it out, shower, then repack. That gives them an excuse to be like, oh, okay, cool, I can actually shower now. Now, if there's signs of cellulitis, then that's when we treat with oral antibiotics. Okay, approximating tissues. Closing the wounds without tension for best results. So we can marsupialize the tissues, kind of releasing that bottom sub-Q, where we can then move the upper layer of the dermis and the epidermis over more to release the underlying tension of the tissues. This is not something that you normally do in primary care. This is something that surgeons will do in the OR. Okay, but just know that this is something that you may see. They're trying to make enough tissue so that they cover it and not cause compartment syndrome. But it is something that you can see. All right, negative pressure wound backs. You'll hear it just called wound back. Normally you have this black sponge that goes up inside the wound. This is like arts and crafts, right? We want it to fit the wound. If it's a very irregular sized wound, you are cutting that thing to fit that wound pattern. You do not want any black overlying the tissues. Okay, so you can see here we have a very irregular wound. That wound, or the black sponge, is only within that wound tract. We cover it with basically huge tegaderms. We cut a little spot over the tegaderm and over the sponge. We attach what's called a lily pad on top of that, which then has a tube that goes to the actual machine and causes suction. Biggest complication with these is if they leak, meaning leaking air, the surrounding tegaderm, the surrounding tissues don't have enough surface purchase, and air is getting through it and into the black sponge from the outside edges. If that happens, most of the time your first line of defense is putting more tegaderm down over those areas to see if we can seal off those leaks. If we can't and it continuously alarms, then we have to take it all down and put a new one on, unfortunately. Stimulates the fibroblast activity to repair the underlying tissues. The other part of wound vacs, so we can use it on, like I said, when we leave the belly open, there is a special type of sponge that if it's a small enough area, potentially, it's a white sponge. You can put that on top of intestines. It's a very fine sponge. It will not suck up and cause irritation to the intestines itself. You can literally put it directly on top of intestine. And then you put the black sponge on top of the white, and then the tegaderm, lily pad, all that jazz. Okay? So this is just this is used for large wounds, very wet wounds without infection. We're going to do all that. So that picture up there, that is a wound vac that is not under suction. Okay, that is a wound vac that is not working correctly. So if they walk into your clinic and you see that, you have to take that off because you have no idea how long it's been not functioning right. And you have a bunch of bacteria and stuff in there that now you have to make sure that you clean out. Okay? All right. Staph aureus are our most common source of bugs in terms of skin and soft tissue infections. We talked about that a little bit already. Basically, we see this when operative areas fail to heal. You're going to have foul smelling discharge. We have to irrigate and debride. We may or may not need oral or IV antibiotics. We may require another trip to the OR, depending on how bad it is. Okay. A lot of times we will continue, like open it up, try to irrigate it, debride, and then wet to dry packing. If the wound is infection, remove all closures. Don't try to reclose the wound. This is not new. Place on IV or PO antibiotics if cellulitis is present. Make sure that you're calling the surgeon. If it is a pretty recent post-op infection, there are irritations that may look like infections. So don't assume all wounds are in fact actually infected. They may just be irritated. Okay? So make sure that you are contacting that surgeon, especially if you have any doubt. Now, if it's fevering, the wound is broken open and it has purulent discharge coming from it and it smells foul and is very red and warm and irritated, like, yeah, that's an infection. Right? But, what do you think about that one? Do you think that's infected? Who thinks it's infected? Who thinks this just has a allergic reaction from the dermavant? Allergic reaction from the dermavant. So we peeled off the dermabond and let her heal from the rest. This little piece of white, or it's like a yellowish tinged fibrous material, that is just your normal fibrous tissue healing the wound base. Okay? So you just see it versus normally you don't. Okay? So this is just very irritated, very, like it has an allergic reaction from her lumpectomy. Okay? So not all wounds that look like this are infected. Every time we put a post-surgical patient on an antibiotic, that surgeon gets dinged for a surgical soft tissue infection. Okay, your hospital then gets a report of how many soft tissue infections that surgeon has. If they're over the threshold, they may get counseled, they may get reprimanded, they may get, things happen to them in the military world, it's not that bad. But in the civilian world, they may lose their bonuses, they may get fired, right? If they're costing the hospital money because their cervical soft tissue infections are high, they may get fired, right? So when in doubt, just contact that surgeon and have that surgeon actually then say yes or no, that's an infection. All right, let's talk about number 1. What do you see? What do you think happened and how would you manage it? What do you see? Is this healthy tissue? No. All of this black is what? It's an eschar, it's necrotic tissue. Okay? What do you think happened? No. It's not a bite.
Thunder Lake shape.
Diabetes.
Nope.
Diabetes.
Nope. Nope. Anybody catch the surgical incision here?
Fans moving. I think I can see.
And look at this one. So this is a post-op complication. This is someone who is in a cast. Post-operatively, ortho fixed their ankle. It leaked inside the cast, then caused necrosis. Okay, skin tissue breakdown. She did not come in soon enough. She thought, oh, well, it's wet, it's fine, it'll be fine. I'm fine. I don't want to bother them. Right? So this is why we consult, or we can educate the patient. Like, hey, if anything feels off, if it's weird inside, you feel wet, you feel pain, you don't feel pain, like, whatever, right? They should come in. She went back to the OR and had it stent. I think she stayed at the hospital for about a month. So, what about number 2? What do you think happened? What do you see?
Old man.
Not extravasation. Good guess. Nope. Is this an old person or a young person?
Old guy.
Old. What do you think happened to their old, frail skin?
Ding
Skin
it.
tear, right? You can see where the rest of that is starting to heal. Right? Nice pink, new skin. What's that thing in the middle? Nope. It's on a wrist. It's very unlikely you get a DQ ulcer on the wrist. Very unlikely. Because normally we have people that like this. This is on the front part of the wrist. So you have skin tear. It is a little hard to see, but that skin is hypergranulated over the level of her normal tissue. So this is a chronic wound that is refusing to heal, refusing to switch back into her normal tissue healing like the rest of her skin tear. How do you treat this? Silver nitrate, very good. Number 3, what do you think?
Dog bite.
No,
Human.
a lot of people bite. Not a bite. Not a bite.
Shark.
Not a shark bite, not a bite. It is on a calf,
It's 100%.
but what do you see? Regardless of what happened, what do you see? Necrotic tissue, right? You see that black, okay? So this is someone who got their leg caught on a fence, on a fence post, okay? Dirty fence post. So chronically wasn't healing right. He came in. We had to debride as much as the black tissue as we could, the necrotic tissue. Said, hey, go do some, wet to dry or damp to dry, dressing changes. We'll see you back in a couple weeks. Then he came back with that. What do you think? Might be a failure to comply, sure. They did say that he was doing his dressing changes every day, if he was supposed to. This is just a chronically healing wound, right? It's not getting any smaller. He has basically the treatment failure of wet to dry dressings. Whether he was doing it or not, the treatment failed. This can happen, right? So we took him back to the OR, debrided as much as we possibly could, and put a wound back on. Okay? These things happen. But you have to be aware of them.
He's dead. Like his soul.
Oh no. Alright. Hopefully my computer doesn't restart because it was saying it needed to. Okay, 5 more minutes. So, contraction versus contracture. Okay, this is important in when we are trying to figure out wound healing. Okay, normally we want contraction of the skin. Okay, we want contraction of that wound, have it smaller, right? Heal from the inside out. Contracture is where something happens, the tissue is not healthy enough, most likely from a burn, and the skin healing process is distorted, and so the skin actually contractures down instead of just a normal contraction. Okay? So this is why when we have people having burns, we put them in splints to keep their hands out so they don't contract down. Okay? Certain mechanisms of burns, chemical burns, electrical burns, right? The tissue gets distorted enough and damaged enough that that healing just doesn't happen right, and so when it heals, it actually becomes shorter. Okay? And smaller. So instead of healing in a normal linear way, it actually really contractures down, and you have to then do specialized plastics and/or burn plastics. Will go in and do specialized release of those contractures so that they regain function in those regions. Okay. All right, chronic wounds. Affects a lot of people, costs a lot of money. Basically, like I said, it basically fails to heal in a timely fashion. Okay. Normally we see these in someone who has already a disease state like diabetes, obesity, malnutrition, immunosuppression, infection. We rarely see chronic wounds in otherwise healthy people. Okay. So this is a diabetic plus a peripheral venous stasis ulcer that has become woody. It actually has little tendrils of skin in there. It was very interesting to see. Very hard to treat. Then you have just these normal ulcers that just don't heal. So what do we need in order to heal wounds? We need oxygen, we need nutrition, we need appropriate wound beds. Okay, if we don't irrigate and debride those tissues enough, we're just causing that chronic stasis to continue, right? A lot of times when we're trying to get all of that dead tissue off, we actually have to cut until we actually get healthy bleeding. We're not just cutting off the dead skin, we're cutting off skin enough and tissue enough that we've reached bleeding. Okay? It sucks. Sometimes it really is a bloody type of thing, which is why we do it most likely in the OR. Why do you think we do that? Why don't we just cut the dead tissue off and say it's good? It's probably that tissue that's not bleeding is already dead. It just hasn't turned into that eschar because the eschar was on top. Right? We cut off the eschar, that tissue is still dead. It's just not eschar because is already started up. Okay? So we really have to get down to that healthy bleeding in order to make sure like that we're actually getting to a capillary bed that's actually going to help supply it and hopefully get it back into a normal, healthy rhythm. Okay? And then moisture. Moisture is really, really important. We really want the Goldilocks of tissue moisture. If there's not enough, it's going to be dry, it's going to be painful, it's going to crack, it's never going to heal. Okay? But if it's too wet and it's soupy, guess what? None of the debridement happens, none of healthy tissue cell turnover happens. It just becomes macerated. Like think of you're in a pool for a long time and your skin just becomes very wet and you know, be a paper cut and all that tissue is just saturated. Right? It's not going to heal right until it dries. But if you have dried, cracked hands, right, that also doesn't heal correctly, or you know, whatever, right? So we really have different tissues or different gauzes and different treatments that we can use depending on what it is, whether it's too wet or too dry. Okay. All right. We talked about stasis or peripheral wounds with diabetes already, and it's now 14:50. So we'll start here. Carl, enjoy the rest of your night.
Chemo.